Bismillah ar-Rahman ar-Rahim. I'm going to talk about a very hot topics in pediatric orthopedics, which is idiopathic intoeing. This topic is very important and it's very hot because there is no single day in outpatient clinic without multiple cases presenting with intoeing. It's a very common presentation in pediatric orthopedic practice. And usually this presentation is in a form of a lot of concerns and anxiety from the parents about their children. Some of these may be the shape of the gait, whether this deformity or this abnormality will cause tripping and repeated falls of the child. Does this will affect this child in the future, causing some problems of the joints, some arthrosis or arthritis? And what about their athletic career if they are going to be professional athletes? How does this intoeing will influence them? A lot of concern, a lot of questions that needs answer. And what is the treatment of this problem? What is intoeing? Intoeing is some sort of abnormality of the foot progression angle. Normally, the foot progression angle is the angle of the foot along in relation to the line of progression of the gait. And usually, in the majority, this angle is 0 to 20 degree external rotation or out-toeing. So we normally walk in out-toeing within the range of 0 to 20 degrees. And this rotation profile and this foot progression angle is summation of version of the bones, rotation of the bones, shape of the foot, capsular pliability of the joint and muscle control, and it is related to the age. Normally, the femur is anteverted. What is the meaning of anteverted? That the axis of the neck is externally rotated to the axis of the condyles. So the femur is twisted so that the neck femur is anteverted and looking anterior. And the higher the anteversion angle, the more the internal rotation of the hip. And the lesser the anteversion angle, the less the internal rotation and more is external rotation of the femoral head, of the hip joints. The tibia is externally rotated, so it's twisted to outside. So the bimalleolar axis of the ankle is externally rotated in relation to the proximal tibial plateau axis. It is rotated about 10 to 20 degrees. How to assess rotation profile? If the child is walking with the foot is looking inwards, this means that the foot progression angle is negative, is less than 0 degree. But if it is walking with external rotation to the line of progression of gait, in this case, it is walking without toeing. The out-toeing, if it is within 20 degrees, is normal. If it is more than 20 degrees, it is abnormal external rotation or out-toeing. But any degree of internal rotation or less than 0 degree, it is intoeing, which is, we will see, is it physiological or abnormal. So the first line of assessment is to see the child walking and to determine whether he is walking with intoeing or walking without toeing. The level of deformities may be at the level of the femur, at the level of the tibia, and the level of the foot. In the femur, increased femoral anteversion is a cause of intoeing because it will increase internal rotation of the femur. The tibia, internal tibial torsion, which is abnormal because normally the ankle is rotated externally 10 to 20 degrees. And the presence of metatarsus adductus at the level of the foot is a cause of visual appearance of intoeing. In this lecture, I will talk about the femur and the tibia as a cause of intoeing. To assist the patient, start with the femur, and also for examination of the tibia, the child should lie prone. And the assessment should be done in prone position. And why to assist the patient in prone position? Because this is the position of extension of the hip. And when we walk in a position of extension of the hip. So to assist the proper rotation of the hip joint while we are walking, the child should be put in a prone position and assist the rotation of the hip. The hip should internally and externally rotate about 45 degrees with the upper limits of internal rotation about 60 degrees. In presence of increased femoral anteversion, there is increased internal rotation, as we see here, and limited external rotation. And this position and using the axis of the tibia as the line of a goniometer help in assessment of the degree of rotation in a precise way. This child with increased femoral anteversion, when they walk, the femur is rotated, it will take with it the tibia and the foot. So the patella is looking inward and the foot is looking inward also. This is increased femoral anteversion. And because there is increased internal rotation of the hip, these children sit in a W setting because they have increased internal rotation of the hip, but they cannot externally rotate enough to say in an external rotated position or cross-legged position. To measure the degree of femoral anteversion, we have to put our hands on the greater trochanter and do internal rotation till the greater trochanter is maximally prominent. And when it is maximally prominent, this is the degree of femoral anteversion. This is a clinical way to measure the femoral anteversion. To measure the tibia, internal or external rotation or version of the tibia in the same position of the patient with the knee flexed 90 degrees, we have to look on the axis of rotation of the foot. So it is mandatory to use this technique to measure the femoral the tibial rotation is to have a normal foot. We cannot measure the tibial rotation in this position if the foot is abnormal. Whether it have varus deformity, it will give the impression of internal tibial torsion, or severe valgus deformity, it will give the impression of increased tibial external rotation. The axis of the foot is aligned from the center of the heel to the space between the second and third toe, and it should be externally rotated about 10 to 20 degrees up to 30 degrees in relation to the thigh axis. So we measure the foot-thigh angle. And this angle will be between -5 to 30 degrees. This is a normal angle. If it is internal rotated, then we have internal tibial torsion. If it is more than 20 or 30 degrees, then it is external tibial torsion. Also, we can measure it by using the bimalleolar axis if the foot has any form of deformities, by flexing the knee at the edge of a table and then holding the malleoli, the median lateral malleolus, and then measure the degree of external rotation. One of the signs of external tibial torsion, if the child is walking in a normal foot progression angle, then the child has to internally rotate the knee. The knee is looking inward, the patella is looking onward, but the foot is looking outward. This means there is external tibial torsion. This patient has extreme degree of internal tibial torsion. The foot is looking onward, but the patella are looking forward, straight forward patella. But this child has increased femoral anteversion. The foot is looking onward and the patella is looking onward also. If the patient has both increased femoral anteversion and internal tibial torsion, he will have a severe degree of intoeing. One type of the malrotation is a severe form. It's called the malicious or miserable malalignment, and it is increased femoral anteversion and increased external tibial torsion. And this patient usually walk with rectus foot and neither intoeing or outtoeing, but the patella is looking onward. And these patients has a combination of external tibial torsion and the increased femoral anteversion, and this is usually the most pathological form of tibial and femoral malrotation if we have this combination. We can use investigations. The CT could be used for assessment of rotation by taking cuts at the level of the condyles and the level of the femoral neck, and also at the level of the proximal tibial condyles and the bimalleolar axis, and to measure the rotation. But this is not a routine investigation at all. We shouldn't ask for this investigation unless we are deciding to go to surgery and we have to document the degree of rotation. It is not used even for decision making for doing surgery. So please avoid asking for this investigation because it will not add anything for the diagnosis, just the diagnosis of the case. How this rotation profile develop? Usually we are born with extreme increased femoral anteversion. The femoral neck anteversion is about 40 degrees at birth and continue to decrease later on along the age up to 9 to 10 years. Also, the last month during gestation, there is molding of the child. The child is squeezed. And in this position, the tibia is internally rotated and the foot is internally rotated and the hips are externally rotated. So the child is born with internal tibial torsion. And sometimes some metatarsus adductus that's passively correctable and will improve with growth. So the child will have increased femoral anteversion, internal tibial torsion, some degree of metatarsus adductus. So it is expected once he starts to walk, he has to walk in toeing. But this does not happen. And the child usually walk with rectus or out toeing. And that's because during this molding of the child in the pelvis and in the uterus, there is a development of external rotation contracture of the hip, soft tissue contracture of the hip. And this soft tissue contracture of the hip will mask the increased femoral anteversion and will mask the internal tibial torsion. And this external rotation, soft tissue contracture will disappear along the first 3 years of life. So the intoeing gait usually appears after that. And if the child is born premature, then this molding will not happen. And this child may present early with increased femoral anteversion and may not have the normal internal tibial torsion. So the natural history is spontaneous improvement of the external rotation contraction and spontaneous improvement of the increased femoral anteversion and the internal tibial torsion. And the bony rotation improve spontaneously up to the age of 9 to 10 years. The tibia external rotate about 15 to 20 degrees, and the femoral anteversion decrease by about 25 degrees. The improvement is affected by the family history. If the mother or the father or in their families, they have a history of difficult cross-legged setting, and they like to set in increased femoral in W setting, or have this history, this means that this child may develop a normal foot progression angle, but will stay having difficulty in cross-legged setting, and they prefer the W setting because they have a positive family history. So taking a family history is important to predict what is in the future for these children. What is the biomechanical effect of torsional deformities? Normally, when we stand in a metastance phase, we have the foot looking forwards, and we have a passive knee extension of the knee and passive knee extension of the hip, because the ground reaction force pass anterior to the knee and anterior and posterior to the hip. So the ground reaction force is affected by the length of the foot. So the longer the foot, the more the anterior, the ground reaction force, so the more the extensor power on the knee. When we have either external rotation or internal rotation of the foot, the functional length of the foot is decreased. And so the ground reaction force distance from the center of rotation of the knee is decreased. And so the passive extension power to the knee is decreased. This is usually not significant in a normal children, but it is significant in paralytic problems like cerebral palsy, myelomeningocele, and other paralytic problems. The second effect is because of the functional length of the abductor is affected by the rotation of the hip. When the patient has increased femoral anteversion and it is external rotated, the lever arm of the abductor is decreased. And when these patients walk with internal rotation, they will stretch the abductors and will increase the lever arm of the abductors. And so the abductors will not get fatigued early and will exert lesser force to abduct and to maintain balance and to maintain the balance of the pelvis in metastance. This is observed when it is observed. Usually some parents saying that when I ask my child to walk normally, he can walk and adjust his gait, but cannot do it for a long time. And this could be explained by this, because when he walk normally, the greater trochanter will be located posterior and the lever arm of the abductor will be decreased. And this will produce fatigue of the abductor muscle. So the child, after long walking with the foot straight, he will rotate it internal and go and continue his walking with intoeing to increase the efficiency and decrease the abductor fatigue. Also, some parents notice that the child can adjust his gait during walking, but once go upstairs or go downstairs, he has to do intoeing because this will produce more advantage for the abductor muscle and improve the abductor muscle power. So after knowing the rotation, how to examine, how to assess, the patient present with a lot of concerns. Usually the mother and parents complain about the child is give a fall repeatedly on the ground. They have tripping because the foots interfere with each other's. Sometimes they refer pains in the body and pains on the lower limb to this intoeing gait, especially pains around the knee, pains around the ankles, and some raise concerns about he is a player, he is a football player or a runner. How he will go with this deformity? My child is always is sitting with a W position, and I usually get angry with him all the day to prevent this gait. And most of them come, frankly, I don't like this gait. I don't like the shape of this gait. So we have to start with to reassure them. And the treatment is observation and observation and observation. A lot of observation, a lot of reassurance. This is not a pathological problem. Let us start by how to reassure them. First, it does not cause tripping. And usually toddlers repeatedly fall on the ground, either with intoeing and without intoeing. But because the parents are concerned with intoeing, they refer anything to this intoeing. The shape of gait, a lot of people have intoeing gait, and we have to ask the parents to start to observe the people around them, the movie stars, the singers, the football players, to notice that a lot of them, a good percentage of them have intoeing. And this does not prevent them from being famous and good players and good singers. And it didn't prevent any mental or functional or athletic development. Usually the parents are concerned about W setting and usually told from their pediatric physician or physiotherapist to stop W setting. It is dangerous. It causes a lot of problems. Usually, actually, W setting is a result and it's not a cause. W setting is not pathological. W setting is a setting because the hips internal rotate more than external rotate. So it is not a problem at all. It does not prevent correction. It does not help improvement. Preventing the W setting will cause a psychological problem with a child, but will not help him to improve or to treat intoeing gait. There is no study proved that malrotation or internal intoeing gait will cause joint osteoarthritis. Only in case of measurable malalignment or measurable malrotation of increased femoral anteversion and external tibial torsion will cause patellofemoral osteoarthritis. Otherwise, it does not cause osteoarthritis. Lastly, it does not interfere with physical activities. An important study has confirmed that significantly more sprinters intoe during sprinting. And even patients without intoeing, but they are professional sprinters, they intoe during sprinting. And this study found that neither a walking foot progression angle nor hip rotation appear to be a factor in sprinting. And even low normal thigh foot angles and sprinting in toe may correlate with sprinting ability. And this is explained because during intoeing, during tiptoeing and intoeing, the foot and the metatarsal break, because we have a shorter fifth metatarsal, the line of setting of metatarsal breaks is perpendicular to the line of progression of sprinting. So it will be more efficient during running than if the foot is externally rotated. And that's why sprinters are in toe intentionally to improve the efficiency of gait. So in towing does not interfere with physical activities. Look at professional player or athletes in Olympic Games. You will find a lot of highly demanding athletes with intoning. What to do during observation? We have a lot of patients coming with special shows. They have been ordered special show or using the left one on the right side and right one in the left side, or using casts, sometimes twister cable or twister brace, or doing a lot of physiotherapy. I have patients spending years on physiotherapy to treat increased femoral anteversion. And they are struggling with their patients to prevent W setting, but they are failing to do so. So what are the one of these interventions are effective? The reality is none. No, none is effective. There is nothing in orthopedics called opposite shows. This child does not need any medical show. This child does not need any braces. Twister cables are dangerous and they have drawbacks on the stability of the knee. And physical therapy has no role at all in this condition. And prevention of W setting has nothing to do. So leave the child sit in the setting he likes. So the only treatment of this condition is surgical treatment. This is the only one. And by doing derotation, osteotomy. And the indications, after explaining all of this, and after explaining that this deformity is only cosmetic, it does not affect the child progression in athletic practice, it does not cause any arthritis, it is a matter of shape. So if the child does not like it, if the parents does not like it, if they insist in correcting it, then we can do surgery. But they have to know they are doing cosmetic surgery. It is not a functional surgery. And this have to be very clear in their mind. And we cannot do this surgery at all unless the child passed the period of expected spontaneous resolution, which about 9 to 10 years. And the second indication for a functional problem is the presence of malicious or miserable rotation combination, and this is indicated in this condition, and this is the only functional indication to correct the malrotation in these patients. The rotation osteotomy for the femur, it could be done at the level of the hip, subtrochanteric area, mid-shaft, or distal femur with the same functional outcome. We can use plates, we can use wires. It is the preference of the surgeons, and also according to the condition of the patient, the obesity of the patient, the weight, tolerance to casting or not. And if we are going to correct the tibia, usually we does not need to osteotomize the fibula, only the tibial osteotomy, and should be done at the level of the supramalleolar area. We have to avoid proximal derotation tibial osteotomy because it's accompanied with high percentage of compartment syndrome. So just words about the technique. I will give an example of the distal tibial derotation osteotomy. We have to do the incision in an oblique manner. So after doing the derotation, the line will be straight. We insert a K-wire parallel to the joint line and above the physis, and then another wire with the required angle of correction in relation to the first one, proximally. And this wire here, 1 and 2, we have the angles now we want to correct. So after doing the osteotomy, this wire will be along the same line. And here, after doing the correction, the osteotomy should be with the power source to be smooth, so the tibia can rotate externally. And here the landmark wires will be parallel to each others. And then I prefer fixation with wires and not using a plate in these cases. And this is after closure. The incision orientation has been changed because of the rotation of the distal segment of the tibia. So idiopathic intoeing is a physiological developmental variance. It is not congenital malformation. It is a normal variance. Not to operate for this patient before 9 to 10 years, and even at that time, it is rare to operate because it is a cosmetic surgery. It is a preference for the parents and not a functional problem. Functional deficit is a prerequisite for surgery, and this is present in a case of miserable malrotation with increased femoral anteversion and external tibial torsion, increased external tibial torsion. And we have all non-surgical intervention are not effective, are not required. And we have to reassure the parents and observe this patient, a lot of assurance and a lot of observation. And we have to mention that we are talking about idiopathic increased femoral anteversion and internal tibial rotation, and other etiologies accompanied with malrotation have other considerations. Thank you.